Hello? Hello?
Hello, sir.
Are you there?
Yes,
Okay.
please.
Thank you.
Yes.
Small thing.
Yeah. We are starting from here today. The pelvic floor muscles. Have you done them? Have you gone through here?
No, sir.
Yeah, so my record tells me that we are starting here this afternoon. But meanwhile, you are welcome after a break for your practicals. Please, my phone is very close to me. If you know my number, if you are not hearing me, there's something problem, you call. So that I make them to rectify. I hope you are listening to what I'm telling you.
Yes,
Hello? We've been talking about pelvic. So this afternoon, we look at pelvic floor. The pelvis itself is a bony structure. And the floor of the pelvis, where the baby will pass through, is made up of muscles. So we look at those muscles. And we look at their importance. So when we say pelvic floor, the floor is a soft tissue and which fills with the pelvic outlets. And those tissues, the muscles, the pierce three holes. When a woman is in the dichotomy position, you see and you displace labias, you see vagina orifice, urethra orifice, and of course you see the anus. So these structures penetrate, and what I'm showing now are the muscles. You look at the arrow, you see the muscles. These are the three structures the muscles are controlling: anus, vagina, urethra, vagina, and anus. And the muscles are surrounding them. These muscles are very important. When they are damaged during birth, it causes incontinence of urine and feces for the woman. So we are going to look at them one by one. When the pelvic floor, when the female pelvis is viewed from below, the center of the pelvic floor seems to project downwards, much like a funnel, with the anal canal in the center. These are the structures I showed. The two levator ani, we see what we call levator ani muscles, and coccygeosis muscles make up the pelvic floor, forming a figure of 8 around the vagina and anus. Now, let me go back to the diagram. These are the anus, and if you look at this, you see something like a muscle. When you go down, what you can see now, it forms like an 8 surrounding this, and they give support to these structures in a woman. So what it means is that they are damaged. When you damage them, you cause problem. The two levator ani muscles and coccygeosis muscles make up the pelvic floor. forming a figure of it around the vagina and anus. Since these muscles support the entire pelvic content, they are of great importance as is shown in the diagram below here. So these muscles support the structure, the uterus, everything is in the pelvic and being supported by these muscles. So we have two types of these muscles. The one when the woman is in the totomis of which you see is superficial muscles, and then we have the one you can't see, which is deep muscles. So the pelvic floor muscles, we have the deep one and we have the superficial ones. Now the deep ones, there are two strong muscles found on each side of the pelvis. Because of luminant bone, we have right and left area of the pelvis. So these two strong deep muscles stop downwards and forward to meet in the middle to form a sling of muscles which support the pelvic organs. Those at the end here, the right side, those at the left side, joined together to form something like a sling, a support for the organs in the pelvis. Now, each one of these muscles consists of the following. We are talking of deep muscles. These muscles, two of them, when you take one, it's divided into, we have three in one. We have pubococcygeus. Anytime you are talking of muscles in anatomy, you look at the origin and insertion. When you have the pubococcygeus muscles, it starts pubic and end at coccyx. Iliococcygeal muscles start with ilion and end at coccyx. And ischio-coccygeal muscles start with ischion and end at coccyx. Don't forget that pubo is pubic, ilio is ilion, and ischion, and all this division is on what we call innominate bone. And coccyx is at the back, a triangular bone which joins the sacrum in the pelvis. Now there are three in number, pubo, when you take pubo. Now these muscles I'm going to describe. What I want you to take note is what did they support? What did they support in women? So that when they get damaged, you know what's happening. When you take pubococcygeus, that muscle is also divided into three. And they all arrive from the inner border and end at coccyx. So the muscle fibers sweep posteriorly at the back below the bladder and surround these structures. So take note of the pubococcygeus muscles surround urethra, vagina, and the rectum. And they meet at the perineal body. Perineal body is between the anus and the vagina, that front there of the woman. There's some of the bladder inserted in the coccyx. So what we are saying is that pubococcygeus muscle, there are three in number, but all of them is one, pubococcygeus. And they support urethra, they support vagina, and they support rectum. So what it means, their damage can cause problem for urine and then problem for the waste physics and as well as vagina itself if they are damaged. That's pubococcygeus. And then we have ileum, two in number. They arise from the white line of the fascia covering the obstetric foramen. The muscles spread out like a fan, overlapping and mixing with the fibers of pubococcygeus. So they mix with the pubococcygeus muscles, forming a firm support behind the urethra, vagina, and anal canal. They sweep downwards and inwards and inserted into the coccyx. So you see what we are saying is that ilio and pubococcygeus support vagina, support anus, and support urethra. These are very, very important. During labor, especially those who are delivered by forceps or vacuum, or those who have a prolonged labor, can cause the damage of ileococcygiosis and pubococcygiosis, and it can lead to incontinence of feces and urine. Note, during defecation, these two muscles layers lift the anus, ileo and pubo, and they are called laveta. They laveta, ana. When you want to nature's call and you feel like going to nature's call and you don't want to do it, you use these muscles to prevent the content of the rectum from coming down. Then we have issue. So the laveta ani is made up of the two muscle layers, that is the ileo and ileo and pubococcygiosis. Then we come to ischio. Ischio, the coccygeal muscles, they are two in number, arise from ischial spine, lying in front of the sacrospinous ligament. They pass downwards and inwards to be inserted into the lateral margin of the coccyx in the lower part of the sacrum. Nerve supply is by pudendal nerve and the fourth sacral nerve. So then we have superficial muscles. So the three muscles I just talked about, pubococcygiosis, starting with pubic and the end at coccyx, ileococcygiosis, that's the end at coccyx, and pubo are the deep muscles. Now we have superficial muscles. It lies in the pelvic outlet under the anterior, of the deep muscles, and they are therefore liable to injury. They are in front of the deep muscles, so they are liable to injury during childbirth. And these are the superficial muscles. Note the names: bulbo, cavernosus, ischio, cavernosus. Transverse perineal muscles, external anal sphincter muscles, membranous sphincter, and perineal pelvic floor. These are the superficial muscles in the pelvis. They lie in front of pubo, ileo, and ischiococcygiosis. And bulbo cavernosus, two in number, and surround the vagina orifice. You can find these muscles in the vagina orifice, superficially, as well as Bartholin glands. They engulf the clitoris. And diminishes the size of the vagina. Sometimes after delivery, the woman, you see that the clitoris is big. And when you see something like that, then this muscle is affected. Bulbococcygiosis. Then we have bulbocavernosus, sorry. Then we have ischiocavernosus muscles. They pass from ischial tuberosities upwards and inwards along the pubic arc to be inserted into capura cavernosus or clitoris. So they are also involved. Ischiocavernosus. They are found around the clitoris, and they can also get engorged. And then we have transverse perineal muscles. Don't forget, we are talking of muscles found in the pelvis. And we are on superficial muscles. They pass from ischial tuberosities, from the central point of perineal body. They pass transversely, and meet those in the opposite side in the perineal body, mixing with the fibers of the pubocavernosus at the perineum. So that's transverse perineal muscles. Then we have sphincters, which are found in the anus. They surround the anus. They help to form the perineal body where it's attached to the muscle fibers. Some of the fibers are attached to the muscle fibers, and some of the fibers are inserted in the coccyx posteriorly. These sphincters, remember I said the muscles we are doing take note of their function in the pelvis. This one's close the lumen of the anal canal. They close the lumen of the anal canal. What it means is that when you damage them, the anus will not be able to work, and the woman will become incontinent of the feces after delivery. It will not be so comfortable for a woman to come to the labor ward and leave the labor ward with that problem, or not able to restrict the coming of the feces because of damage of external anal sphincter. Then we have this sphincter too, the membranous sphincter of urethra. This one, membranous sphincter, control the urethra, where the urine passes, arrive from the pubic bone, circles around the urethra, and back to the inserted into the opposite pubic bone. What is the function of membranous sphincter? Act as sphincter muscles and help to close when you are not ready to urinate. It helps to close the urethra. So can you imagine when during delivery you damage the woman's membranous sphincter? It means the woman can urinate without knowing that she's urinating. Then we have perineal body. This is a triangular shape where when the woman is in the totomy position, look at the vagina and then you look at the anus. The region in the middle is what we call perineal body or perineum. It's very, very important. Sometimes it is cut when the baby is finding it difficult to come. The midwives cut the perineal body, what we call perineum. It measures 4 centimeters on each side, lies between the anus and vagina, and its apex directed upwards. Now, it is a part of the pelvic floor and is formed by the several layers of tissues which are inserted into it. When the midwife cut through the perineum or perineal body, you see that it has layers. It's not just one skin layer. So when they are suturing it, they also suture it in layers. If you suture only the top, what will be left under will get infected, and the woman will get gaping of the wound, and that's very dangerous. So you should know that perineal body is layered. It should therefore be considered as composing. We consider as composing, not therefore because as composed only a skin. Base is covered with skin, and deeper muscles are of fibers or levator anal muscles, while the lowest part is made up of superficial muscles. So we have it's composed chiefly of muscles and connective tissue. It is capable of stretching. Perineum is very strong. So sometimes when the baby is coming through the vagina, it stretches, allow the baby to pass. If it is stretching, it's resisting stretching, that is when the midwives cut through and then allow the baby. Otherwise, if the midwife doesn't cut through and the baby forces its head through it, at the end of the day, you get something we call tear of the perineum. When the fetal head presses against the outlet of the pelvic canal, the central point of lower end is called central point of the perineum. Then we have this ligament, the deep fascia, which create a space between the deep and superficial layer of the pelvic floor, and the space between the bulbocavernosus, ischiocavernosus, or transverse perineal muscle is found in this triangular ligament. The membranous sphincter lies between each layer and is pierced by urethra and the vagina. Its function, the function of this triangular ligament, remember I told you all these muscles we are talking about. When you go back to it, but look at the muscle or the structure and where it's coming from and where it's ending and its function. The function of this is to help urethra and vagina to maintain its position. So the muscles are very, very important. Now, we mentioned all of them, what we call the inner deep muscles and superficial muscles. Lumping them together, let's see the function of pelvic floor itself, or pelvic floor muscles. Their function is this: in the non-pregnant state, it closes the pelvic outlet. 2, it supports the pelvic and abdominal organs found in the pelvic. It resists pressure because of the bubo and iliac. When you are laughing, sometimes you feel like passing an air, but because of these muscles, sneezing and laughing and coughing, it resists the pressure, nothing will come out. It assists in nutrition and defecation. Don't forget the membranous sphincter and that of anal sphincter. When you are not ready to pass through, it resists it. In pregnancy and labor, it helps the engagement of the fetal head, and it softens the muscles. Soften during pregnancy, allows stretching during childbirth. You know, the hormonal influence on them make them soft, and it opens up for the child to be born. It allows flexion and extension of the four presenting part. That's allowing the smaller diameter to emerge through the birth canal. We look at the fetal skull later, you understand. It helps in the forward rotation of the presenting part during labor, and any part of the fetal body which reaches the pelvic floor first, it rotates. It rotates forward and inward, and the born first due to gutter shape action. It acts, the pelvic, we are talking of muscles, what they are doing for the woman. It acts as swing door during the delivery. During labor, the part of the pelvic floor in front of the vagina is pulled up with the part behind pushed down to form an open birth canal through which the baby passes to be born. And then we have, so if these are the functions of the pelvic floor, look at what happened. Pelvic damage. You know, all along, as and when I'm talking, I said these muscles, look at their function and see if they are damaged, what will happen. So we look at the damage of the pelvic floor, overstretching. When you overstretch during prolonged labor, this makes the pelvic muscle relax and loose, which may lead to prolapse of the pelvic organ, such as cystocele, rectocele, prolapse of the uterus. If they are not supporting these organs well, they get damaged when the labor is getting prolonged. The woman is supposed to deliver within 1 hour or 2 hours, the second stage of labor, and it's prolonging. When the woman is supposed to deliver at 18 hours or 15 hours, respectively, as when the person has delivered or not, this could be correct. This can lead to cystocele, rectocele, prolapse of the uterus. They will damage those muscles, and it will not be able to hold the structure. Then, but this could be corrected by pelvic floor exercise after delivery. Sometimes after delivery, we send the woman into pelvic floor exercise. Second, the pelvic floor can be oedematous. You know, especially it is even very obvious sometimes when you ride a bicycle, you can cause edema of the pelvic floor muscles. But most importantly, what is very common in the labor ward is the tear. You hear the midwife saying that the woman has got first-degree tear, second-degree tear, third-degree tear. What is the meaning of this? What is first degree? What is second degree? What is third degree? The degrees are this. For the first degree tear, remember we have fourchettes, and then we have the skin. Only the fourchette and the skin are involved. after delivery. And the wife asks, please let me see what has happened. You go and inspect the vulva, and then you see that the faucet, remember the faucet when we did the vulva, the faucet, and only the skin is torn. This is not a big problem. It's not a big problem at all. We don't suture it. Normally, the advice is that when you go home, go and sit on a warm water. By the second degree tear, anytime we mention the tears, the second degree tear, they therefore have faucet and skin torn, but this time perineum. Perineum is involved, and perineum is involved. It does not read the anal sphincter, but the perineum is torn. This one has to be sutured. If you don't suture it, it will create problem for the woman. This one has to be sutured. And then we have third degree tear. When anal sphincter is torn, in other words, faucets, the skin, perineum, and the rectum completely torn during delivery. Ladies and gentlemen, this should not happen to a woman who has come to a well-defined maternity home or hospital. It's through negligence that the woman getting third degree tear, because it is very, very, what do we call it? Painful, and you need to act fast. The woman has to be sent to the theater for general anesthesia to be given before this is corrected by way of suturing. So take note. So we have third degree, what is the second degree, skin and faucet, second degree faucet, skin and perineum, and then third degree rectum involved. Rectum involved. So take note of that. What normally causes? That's why he said it should not, these tests should be really protected. That is why the midwife has to be in front of the woman and manage the delivery. To allow the largest diameter of the head of the fetus to come out. We'll look at the diameter very soon, and the outlet, okay, during the deflex of the head delivery. When we finish the fetal head score, and then you read here, you understand. Delivery of the head at the height of contractions also cause that. When there is a narrow pelvic arc, the pelvic arc is very narrow, and the baby's head is very difficult to come out. It causes those tears. How do you prevent it? Timely delivery must be employed. Skillful help to deliver the woman must be employed. Otherwise, the complication will be stress incontinent, either fecal or urinary. Remember, I've told you that when ilio, when pubo, when membranous sphincter, anal sphincter are all destroyed, the woman becomes incontinent of feces and urine, and that is very, very bad. That is the complication. How do we treat it? Luckily, surgery can do that. There's surgical repair, suturing, and careful nursing to promote healing. But let me caution you, even though this can be treated, we should not allow it to occur at all. We should not allow it to occur at all. So that is the end of the purpose for the lecture. And another anatomy before we do the rest. Any question? Any addition? And
Sir, please, I have a question.
Sir, on your slides, there is on your explanation on the first degree tier.
okay.
You said surgery is not needed.
On first degree.
Hello,
Yeah,
sir.
I'm listening.
Hello, sir.
I'm listening. Hello? Hello? Hello?
Sir, I also have a question.
What is it?
Sir, you made mention when we got to the prevention of perineal tears, you said timely delivery must be employed. Please, sir, what is timely delivery?
The timely delivery is that if it's a prolonged labor, it can cause the tear. You understand? So if it's a prolonged labor, the midwife or who is managing the woman should know. And if it can't deliver per vagina, then they go and do cesarean section. Or they do forceps delivery or vacuum. You allow the woman to be in labor for force the baby out. It can cause the tear. So that is the timely delivery.
Okay, sir, thank you.
You're welcome. Now, let's look at the So, welcome back. I want to do pediatrics, starting with the fetal score. Are you there?
Yes, sir, we are.
I have 30 minutes to do anatomy, so I'm going to fetal score. You can see the score on the screen, on your screens. What I'm showing here is the fetal score, and according to the lecture program, what I'm showing with my arrow is these are the phase of the fetal score, and from here up to where my arrow is, we call it vault, and then down here we call it base. So that is the fetal score. Why do we go and study fetal score? We'll look at that later. That's very, very important. Fetal score. I think I've jumped the fetal score, this one. I hope you are admiring the fetal score, this one. We have the face there. We have some point there. I want you to look at it carefully when we start describing it. There's a space here. There's some lines here. And this part where the arrow, the big bone here. There's another bone here at the back here, and there's some bones here. That's the fetal score. We call them this one frontal bone, parietal bone, and we have the occipital bone, and we have this side bone here, temporal bones, mastoid and phalanx. You know, this temporal, this bone here. So if you count the number of bones of fetus, we have fetal vaults. We have, so the whole of here is the vaults. The whole of here is the vault. And then we have the face here, and down here, we have the base. So let's start the lecture. Fetal skull. This is the hardest and the largest part of the fetus at term when the baby is going to be born. The head is the biggest, the largest, the most difficult part to deliver. Sometimes when baby is coming, when the fetus is coming with its buttocks, it is the head that blocks, and then they rush the woman to the hospital. The head is big, so if it's not helped, it coming is very, very difficult. But 90% of babies are born head first. That's why we have to learn the head. The fetal skull forms the bony box which protect the brain, and it also serves as a measurement instrument for the pelvis. And it also changes in shape when the woman is delivering the baby. It develops, the skull develops from membranes, the skull bones develop from membranes, whereas most of the skeleton develop from cartilage. The bones that form the vault develop from a single sheet of membranes. About 8 weeks of pregnancy, the whole of the bones are now very, very high. Then growth of the bones continued from within outside. There are some areas of membrane persist between the bones of the fetal skull and those of membranous space within the vault of the skull. They are known as sutures. I'll show you the sutures, and there is a point where all the sutures meet. 2 or more meet to form the fontanelles. So there are 2 things here. We have the sutures and we have the fontanelles on the head of the baby. These sutures, what do? They help for us to know the presentation and the position of the baby. The presentation and the position of the baby. The fetal head is large in relation to the fetal body compared with the adult. Additionally, it's large in comparison with the maternal pelvis and the largest part of the fetal body to be born. Anytime you get any Obstetric book, obstetric, you see that the baby is flexed with a very big head. And this big head is going to be born. So we have to learn the head very well. Adaptation between the skull and the pelvis is necessary to allow the head to pass through the pelvis. You have the pelvis brim where the baby first passes. Some babies come with the big head, some babies come with the small head. Whatever the shape of the head, the baby's head has to go through. So then that's why we learn the fetal skull to know what the fetus does to be able to go through that pelvis inlet. The bones of the vault are thin, palleable, and if subjected to great pressure, may damage and line delicate brain. So that is where I first came first. So these are the whole face. This is the face. This is the vault. This is the vault. And then this is the base. Now, when you take the face, it's not very important to a midwife or obstetric nurse. And it started from supraophthalmos, from the part of the fetus lying below here, supraophthalmos. This is the supraophthalmos. So this part is the face. We are not very interested here because the bones here are not, they don't change in shape during delivery. Then we move on to the base. This is the part which supports the brain. The bones of the face and the base are firmly united and are incompressible during labor and are therefore no importance to obstetric nurse. Incompressible. It can compress it. It can change shape. But when you come to valves, the most important part of obstetricness point of view, compressible, alters in shape, and it composed of 5 bones and 2 adducts. So in all, the vault is made up of 7 bones. They are separated by membranous space called sutures. These bones are separated by sutures. These bones are separated by sutures. Look at the sutures. You know, this one, these lines are the sutures. This is a bone separated from this bone. Another suture is behind. So take note of that. We call them sutures. So the bone, the names of the bones forming the vault, 2 frontal bones, 2 parietal bones, and occipital bone. Then we have sphenoid and mastoid. Sphenoid and mastoid. These are the frontal bone. Let me go to the first diagram there. These are the frontal bone. These are the parietal bone. They are 2. These are the occipital bones, and these are the mastoid bones. So when you calculate them, they are 7 in number, the vault bones. The frontal bones are what I've showed you, and I'll show you the suture. They are 2, and they are separated by coronal suture. The name of the suture is called coronal suture. They are curved and cover the frontal lobes of the brain. And the center of each is a prominent we call frontal bossings. Then we have the parietal bone. These are 2 bones. They lie in either side of the skull. The ossification center of each is called the parietal eminence. Parietal eminence. Then we have occipital bone. It's 1 bone at the back where you have, the back where you have a tipo, whatever they call it. It's a single bone lying below the parietal bones, from which it is separated by lambdoidal suture. That's the name of the suture there. It is roughly triangular in shape and extends from posterior fontanelle to the foramen magnum. It covers the occipital bone of the brain. And then you have the temporal bones. The temporal bones. The spinous and mastoid bones of temporal bones form part of the side walls of the fetal skull. Remember, we are describing the bones of, or we are describing fetal skull. So we have the sutures, the lines that separate the bones. We call them sutures. These are membranous spaces between the bones of the skull. There are 4 in number and are composed of soft fibrous tissues. The main sutures are frontal, we divide the frontal bones, coronal, we divide the parietal and frontal bones, sagittal, we divide the parietal bone and lambdoidal suture. We divide the occipital bone and parietal bones. As I said, frontal bones extend from the root of the nose to the anterior fontanelle, and I described the frontal suture, divide and then we have coronal separating 2 frontal bones from parietal bones, and then we have sagittal. This it is like an arrow which separates the 2 parietal bones, and then we have lambdoidal. It's a Greek letter lambda. That's why it's called lambdoidal. Separate 2 parietal bones from occipital. What is the importance of these bones? In this suture, it helps in overlapping of the skull during labor. When the bones, the head is coming, when there is pressure on the head of the baby, then one bone override come on the top of another, and that has been made possible because of the sutures. And another help with that, it helps us to diagnose diagnose the position of the feature during vaginal examination. If you touch the frontal suture or coronal suture, it means the baby's head is raised. If you touch the back suture, that is the lambdoid, it means the baby is well fleshed. So it helps her to diagnose that. Then we have fontanelles. They are large membranous area lying between the bones of the joint of 2 or more sutures. They are 6 in number, but only 2 are very important. This fontanelles. We have anterior one in front, and then we have posterior one at the back of the skull. The anterior one is very visible to all of us. When the baby is born, you see some breathing, something like breathing in the middle of the head. That is the fontanelle. It's a soft tissue there, and it will gradually close. But initially you see that it's breathing. And I must caution that when it's breathing, it's the brain which is pulsating. It is brain which is pulsating. So any application of any drug there will go and damage the brain of the baby. So the anterior one, as I said, is a diamond shape and measured 3 to 4 centimeters, sutures running into it, frontal suture, coronal suture, and sagittal. They run into that fontanelle. Anterior fontanelle closes when completely ossified by the age of 18 months. The anterior fontanelle, that area which you see breathing, will close at 18 months. That's 1.5 years. So we don't force anterior fontanelle to close by putting any drug there. It is common practice for women to put omega oil or whatever oil, and some tradition put actual drug on that place for it to close early. It is not a disease. If the baby is breastfeeding very well, sometimes it even closes before 1.5 years. The posterior small triangular shape in which 3 centimeters run, they are sagittal, 3 sutures run into it. The sagittal and lambdoidal. It closes about 6 to 8 weeks. And for the back one, it closes within 6 weeks, everything is gone. What are their importance? They also help, the fontanelles also help for diagnosis and position, for us to diagnose the position and attitude of the baby. Right. If the baby head is well flexed, you touch the posterior fontanelle. If the baby is extended, deflects, what will present is anterior fontanelle. So it helps us to know the position, but you can only know that when you do vaginal examination. And you are well fed, you are very experienced, should be able to know. It also aids in the diagnosis of any problem of the fetal score during pregnancy or labor. We first talk of 3 divisions, but we have regions of the fetal score. We break it into regions because of the delivery. Regions of the fetal score. We have the face, which we know already, but the vault is divided into 3. Here, the regions, we don't talk of the base. We have the base, we have the face, and the vault. But the vault is divided into sinciput, vertex, and occiput. I'm repeating. The fetal score is divided into 3 initially: face, vault, and base. But when we come to regions, we don't talk of base again, but we talk of face and vault. And the vault is divided into sinciput, vertex, and occiput. So, as we said, it's called line for supraorbital ridge. And then we have the sinciput, which is the brow. When we say the brow, that is the the forehead. We call it brow. Some babies come with forehead. This lies between the supraophthalmic to the coronal suture. It is very big. The brow is very big. A most unfavorable presentation in labor. Most unfavorable presentation in labor. Then we have the vertex. Vertex is between two fontanelles, anterior and posterior fontanelle on the fetal skull. That region we call it vertex, literally between the two parietal bones. It is most favorable and normal presentation during labor. When the baby is coming, it should come with vertex. When it comes with vertex, then we know the baby is well flexed. But when it doesn't come with vertex, it comes with brow, it means the baby is deflex. And that's the barefoot. Then we have occiputs. It is the region over the occipital bones extending from posterior fontanelle and the lambdoidal sutures to down to the foramen magnum. The foramen magnum, that is the occiput. And so this, once we are talking of a fetal skull, which is round, obviously anything circular should have what we call diameters. So the head, that's like the way we look at diameters of the pelvis. We are now looking at diameters of the fetal skull. And then the knowledge of the diameters of the fetal skull, will help us to understand how the baby moves into the pelvis. So allow them to determine the relationship between the fetal head and the mother's pelvis. If the pelvic brim, which we saw earlier, anterior posterior diameter of the pelvic brim is 11, what it means is that the fetal head diameter, which is going into that, should be less than 11, otherwise it can't enter. So therefore, let's look at the diameters of the fetal skull. I hope you are looking at this structure there. You see a line here. You see another line here. Then you see another line here. These are the diameters of the fetal skull, the horizontal diameters. Now, we are going to name them one by and know their measurement. It's very, very important. We first start with engaging diameter. When we say engaging diameter, what we are talking about is when the fetus is coming, irrespective of the mother, which diameter is showing. Whatever diameter that comes to the pelvic brim is what we call engaging diameter. So this is the diameter of the fetal head that enters the pelvis, and also depends on the attitude of the baby. So the baby to be able to enter easily will depend on the attitude is the relationship of the fetal head and the lens. And when you read the information some of you have for me, you understand what attitude is. It varies from flexion and full extension. Then you have engaging diameter. The small diameter will offer a small circumference. If we are talking of diameters of the head, obviously we are also talking of circumference of the head, and if you have small diameter, it means you have small circumference, and it can easily enter the pelvis. Cannot be altered. These diameters cannot be altered, except that the nurse or midwife will just have it to come out. It can't alter the diameters. This prevents injury to the mother and the baby. So what are the common diameters? These are the names. We have longitudinal diameters and we have horizontal diameters. The longitudinal one and the longitudinal diameters, the names are there. Sub-occiput. So when you look at the occiputs, we divide the head into three regions: occiput, sinciput, and then we have vertex. So sub-occipital, pragmatic diameter. When you hear pragma in fetal skull, we are referring to anterior fontanelle. So, and this diameter starts from the occiput to fragment, that's 9.5, it is found in the well-flat vertex presentation. It is taken from below the occiput to the center of the fragment. Near the occiput, the center of the fragment. And it is the measurement is 9.5. Then we have occipitofrontal diameter also from occiput at the occiput, the back of the fetal skull. And that one 11.5. It passes from occipital protuberance to the root of the nose or glabella. And then it occurs when the head is deflects. This diameter comes to the pelvis when the head is raised, it deflects, and it's found in the occipito-posterior position. When the baby is at the posterior position of the pelvis and the occiput is pointing. Then you have suboccipitofrontal diameter. This is measured 10 centimeters. It measured from below the occiput to the center of the sinciput. So you go below the occiput and come to the front where the forehead is, and it's 10 centimeters. And then we have submental. Mental is the jaw. Mental, pregma. It also goes to the pregma. That is the anterior frontal. And the measurement is 9.5. But this is a very bad diameter, because when submental pragmatic diameter is pointing, it means the face, the baby is coming with the face. The baby is coming with the face, and that is not favorable at all. Then you have submental vertical diameter. It measures from the junction of the chin and the neck or center of the vertex. It is 11 centimeters. So these are all not the mental vertical diameter. It measures mental vertical. So mental from the mouth, the chin area, vertical. And that one is 13.5 centimeters. Don't forget, a good pelvis with the round at the inlet of brim is what? 11 centimeters. So all this diameter shows that the baby is not coming with a good diameter. So you have to take note, 13.5. And then we have transverse diameters. That is the biparietal bones. That's a transverse biparietal. And that's 9.5. And then we have, it lies between two parietal eminences. And then you have bitemporal. It measures 8.2. It lies between the extreme ends of the coronal suture. Remember, I'm saying that because the head is circular, it has diameters. And therefore, anything you hear of diameter, what comes into your mind is in a circular form. So therefore, we go to circumference. Circumference. We have three main circumference on the fetal head. And the first one we talk is suboccipitopragmatic circumference. Remember, we have suboccipitopragmatic diameter. So this is its circumference. And in this form, this is measured from around the suboccipitopragmatic diameter and biparietal diameter. It's a good circumference, which allows the baby to enter and measure 30 to 33 centimeters. And then we have occipitofrontal circumference. It measures 25. It is taken from around the occipitofrontal diameter. It is the point which presents in the birth canal when the head is raised, when the head of the baby is raised, and the baby is coming face to pubis. It's looking at the face of the baby mother, that's the face to pubis. The baby should look down. So when the baby comes with the face looking at the mother, it means occipitofrontal circumference is presenting. The part presenting causes prolonged labor because it does not fit well to stimulate uterine contractions. When the baby is coming with the face, the facial bones don't change. So it doesn't simulate contractions and therefore make. Then we have mental vertical circumference. It is the largest circumference and measured from around the mental vertical diameter. It cannot be born per vagina, as the head is partly, completely or partly extended, with the chin presenting. When you have the brow presentation, the baby is coming with the forehead, then it means mental vertical circumference. It causes obstructive labor and is known as brow presentation, measured 38 centimeters. So it cannot, such a woman who have a baby coming with such a circumference need an operation. If the baby cannot be born per vagina. So therefore, presenting diameters can be named like this. Some presenting diameters are more favorable than others for easy passage through the pelvis. The attitude of the head determines which diameters will present in labor. The presenting diameters determine the presentation of fetal head, of which there are three. One, vertex. When the baby is presenting through vertex, then the diameters are as follows. Please take note. Suboccipitopragmatic diameter and biparietal diameter. That is vertex presentation. This is a favorable diameter for delivery of the fetal head. Those talking, can you give us time? Please, those talking. So we have the vertex presentation being the best, very best. So when the head deflects, the presentation diameters occipitofrontal and biparietal, not a good presentation. This situation arises when the occiput is in the posterior position of the pelvis. Face presentation, when the head is completely extended, face to presentation, the face is coming. The presenting diameters are the submental pneumatic, that's not, and bitemporal presentation, face. When the face is coming, if you do a vaginal examination of a woman whose baby is in the face presentation, the baby licks your hand, and you know the baby is coming with face. And the baby licks your hand because it doesn't want any damage of the face or of the eyes. And then we have brow presentation, when the head is partially extended and the mental vertical diameter, it shows, and the bitemporal diameter. And if this presentation persists, vaginal delivery is not likely at all. So this is where we end with the fetal score. Next week, God willing, we'll continue with the fetal score molding. So we've been talking about labor. So we're going to start labor. But before that, if you have any question you can ask. All right, so welcome back. Welcome back. Yeah, so let's look at labor. Let's look at labor. We are told to look at normal labor. What do you mean by normal labor? The normal labor is what, when we say abnormal labor, is different from the normal labor. We are supposed to treat normal labor. And the normal labor, we are going to listen to any labor is physiological termination. When we say physiological termination, if you take a drug and then you remove pregnancy, it's not a normal labor. The pregnancy should mature 280 days from the last menstrual period. And then physiologically, the baby comes out. Then we say normal labor has taken place. Physiologically, no intervention. You don't tamper with it. Then we say normal labor has taken place. The process by which product of gestation. What is inside? When you say gestation, pregnancy is expelled, through the birth canal. That we say that's normal labor. 4 main factors should be present for the labor to be normal. The baby should present with vertex. We just heard of vertex presentation. And it must be spontaneous, no external force. It should come by itself. It should complete within, if the person is primigravida, that's the first pregnancy, and she's gone to labor, then that labor should last maximum 24 hours. It should deliver. And when she's contracting, the strength and duration and frequency of the uterine pump must be normal. Not a situation where the strength, the frequency is erratic, And when she delivers, she should bleed. If a lot of bleeding is coming after delivery, then that labor is not normal. Something has to be done. The health team managing the labor, when a woman comes into the labor ward, should know that the ultimate goal when the woman steps into the labor ward is to deliver her live baby and give it to her, and make sure the woman too goes home healthy. That is the objective. The prognosis of the labor depends on continuous assessment of the above 5 factors. And what are the 5 factors which we just talked about? Fetus presentation, spontaneous delivery, and must complete within 24 hours. So if these are, there's a deviation from any one of these, then the labor is not normal. The labor is not normal. Before a woman goes into labor, she has these feelings, and these feelings we call the pre-monitoring signs of labor. If a woman complains to you that this is happening to her, and her abdomen is big, then you should diagnose her as somebody who is about to deliver. Please, can you give us opportunity to talk? Those who are talking.
Ahmed, please mute your microphone.
Please, can you give me opportunity to talk? So we have these signs when they occur and the woman complains to you or reports to you. You should know that they are not true labor pains, labor signs per se, but they are pre-monitoring. It means the labor is close. Lightening taking place 2 to 3 weeks before term, frequency of menstruation, forced labor pains, and taking up of cervix. If this happens, then you should let the person know that you should prepare herself for true labor. So the lightening, lower uterine segment soften and the baby goes down. The 2, when that happens, pressure on the lungs is released, the pain of the back and everything is in a primary gravity with a good muscle tone, the head engaged. Then you have frequency of menstruation because of the pressure on the bladder. Don't forget, the bladder is the anterior part of the uterus. So when the mother is about to deliver, she complains of, just like the beginning of the pregnancy, she complains of nutrition or the pregnancy, she complains of nutrition. And then you have forced labor pains, which start, you know, we call something we call Braxton Hicks contractions. If you remember, they become stronger and stronger. And we have taken up of cervix. You do vaginal examination, you see that the cervix has gone up, then the woman is closer to deliver. But when this thing happens, then the woman is in true labor. You can't waste time with her. She has to be sent to the hospital or she has to go to the hospital. Painful uterine contractions, which are not stopping. They have intervals and the pain will come. Another interval, the pain will come. Then you see show. Show is operculum that covers the pelvic canal, the cervical canal, and comes out when the os is dilated and it comes with blood. Then it means the os is dilated and cervix is completely gone out. That is true labor. These are the true signs of labor. When this happens, the woman is severely in labor. So as I said, painful uterine contractions, rhythmic, and they occur regularly. They are also intermittent, so as to give some relief to the mother and also restore circulation. Then we have, so, as I said, plug of mucus, which occupies the cervical canal during pregnancy, escape from the vagina as us dilate. The mucus is blood strained due to rupturing of the capillaries of the deciduum, causing blood bleeding as some of the membranes of the chorion become detached. Then we have dilatation of us. This is felt on vagina as amidst the bag of membranes will be felt to be tense, bulky during contractions. And when no cervix is felt any longer, the os is said to be fully dilated. Now, the labor is in stages, and it's the extent Labor is in stages and it's extent. We have first stage, we have second stage, we have third stage, and we have fourth stage. In other words, labor is in 4 stages. 4 stages. What we call first stage. And first stage begins when the woman complains of pain. It will continue like that, continue like that, continue like that, until the us get fully dilated. In the word, that the first stage has ended. I'm telling you, first stage of labor is pains until this us is fully dilated. The first stage has ended. Then we have second stage of labor. Commences full dilatation. Immediately dilatation ends, full dilatation ends the first stage. Second stage also begins. And the second stage take 1 hour for the baby to come until the baby is. So, and then we have third stage. And the third stage is separation of the baby and expulsion of the placenta. That is the third stage. This take 1.5 and to 1.5 hours. I'm cautioning you, in the labor ward, timing of these stages is very, very important. If the stages are not timed, you don't know whether it's prolonged or not prolonged. First stage take up to 24 hours. You know, it starts from the house. The woman takes a very long time to deliver. Second stage about 1 hour and takes about half an hour. These hours are very, very important. So that is the fourth stage is a period of observation. When the woman, the fourth stage, the woman is observed after the baby is delivered and the baby is taken away. What happens in this stage?
Please, can you go back on the stages of the labor?
The stages of labor, we have one, first stage, second stage, third stage, and fourth stage. Each of these stages are distinct. When we say distinct, you see it starting and ending. You see it starting and ending. So the first stage, as soon as the woman complains of pain, and then you do your vaginal examination and it's opened, and then show has come, and cervix is taken, then first stage has begun. Until that os which has opened is fully dilated. Second stage, full dilatation of the cervix until the baby is delivered. Second stage is finished. When the baby is delivered, you wait to deliver the placenta. That is the third stage. And the fourth stage, the mother is taken to lie in ward, and you observe her. And that observation is very, very important. Each one of these has a time factor. Time is very, very important. You have to time the person. Otherwise, you will not be able to know whether it's a prolonged stage or it's not prolonged stage. Because when the labor is prolonging, something has to be done to the woman. Now we come to physiology of the first stage. When we say physiology, we are going to look at what happens under these stages. So prior to the onset of labor, the pregnant woman may experience some painless contractions. That is the premonitory period. Hardening of the uterus more frequently. So that is bracing his contractions. Then she may also experience occasional spasmodic pain in the lower abdomen. Then in true labor, when the woman is in your ward and she has come to your ward, she experience pain. This pain that the woman is experiencing are felt at the sacral region or lower abdomen. The contraction have a definite rhythm. and gradually increase in strength as the labor progresses. The contractions, and duration of time to reduce. If the 4 minutes is contracting and relaxing within 10 minutes, it will come to a point to contracting and relaxing within 7 minutes. As and when the labor is progressing, the intervals may last for 30 minutes, and this reduces until the end of the second stage, where the contraction may have intervals of 2 to 3 minutes. So the contraction comes and then reducing. And in the process, it will be pushing the baby out. The contraction makes the muscles fiber shorter, thicker, resulting in hardening of the fibers. Some of you have the maternity area in a hospital. Because we are doing obstetrics, please have time to visit the maternity area, have time to finish antenatal clinic, have time to finish the labor ward and then postnatal area. And when you go to the labor ward and the woman is in labor, please have the opportunity to touch the abdomen. You see how strong the uterus is contracted. And a lot of things are involved. Because of that strength, the woman will be in pain. And that pain is good for the woman. Because if the woman is in labor and she's not reacting, there's no pain, then it means the labor is not progressing well. With each contraction, the upper uterus segment, that is the fundus part of the uterus, become thicker, shorter, reducing the size of the cavity and pushing the fetus. For every contraction, you see, in labor, the woman contracts and retracts. It doesn't contract and relax. No, in other words, when she contracts and she's relaxing or retracting, she doesn't go back to where it started. It keeps on reducing the cavity of the uterus and pushing the baby out. That is what the labor is all about. And the lower uterus segment is the passive section. It stretches, dilates, while the upper uterus retracts. The harmonious, working relationship between the upper uterus segment and lower uterus segment formed by isthmus of the uterus, or they work in harmony. And we call that the polarity of the uterus. Then we have another change that takes place, is that there is formation of upper and lower uterus segment, which I've just mentioned. They start from the late pregnancy and is finished during labor. It starts from late pregnancy and finished during labor. The upper and uterine, the upper segment is made up of body of the uterus. Please go back and look at your anatomy, body of the uterus. And the lower segment is made up of straight isthmus of the cervix. During labor, a demarcation occurs between the two segments. It's like a boundary between the lower uterine segment and the upper uterine segment. That demarcation, we call it a retraction ring. And the ridge, which forms at the lower border of the thick upper segment, where it meets the thin lower, is known as a retraction or bandage ring. Let me repeat. During labor, there is a division between, it's the same uterus, but the cervix area has an isthmus which stretches to form lower uterine segment. And it forms a boundary between the upper uterine segment. That boundary, there's a division, and we call it retraction or bandage ring. It is present in every labor and perfectly normal, so long as it is not marked enough to be visible. This division is perfectly normal when the woman is labor. It's a change, but it's not visible. you can't see it. But when you see it, we change the name from the trachea ring to Band's ring. So the name Band's ring is commonly referred to the same with trachea ring, which was not visible and is now visible. So you have to take note of that. And in cases of, when does it become visible? One, in case of obstetric labor, where the fetus cannot descend to pass through the cervix, and the lower uterine segment must stretch to accommodate it, because the fetus is being pushed out of the shortened upper segment. In such a case, a retraction ring will rise and become visible as a depressed ring running transversely or slightly oblique across the abdomen above the symphysis pubis. So that is the second physiology. The second one is the formation of this upper and uterine segment with the retraction ring or Band's ring. Though it's present in all labor, it's not felt abdominally. When labor begins, the retraction longitudinal fibers in the upper uterine segment pull on the lower uterine side, causing it to stretch. This is aided by the force applied by the descending head or bridge. Then the third physiology that takes place is the formation of show. When the cervix dilates, the operculum in the cervical canal is cast out and is mixed with blood, and we call it show. Normally, when you come to the labor ward, or you tell a midwife or nurse that you are in labor, they will ask you, have you seen some water? And they even further ask whether there's blood in it. It shows that show has formed. Then you have bag of waters. As the baby is coming down, in the amniotic cavity, where we have the amniotic fluid, you have the baby covered, in the bag, amniotic cavity, and there is fluid at the baby's, at the buttock, if it's coming with the head, buttocks area, and then fluid at the head area. The one at the buttocks area, we call it bag of, the one at the head area, we call bag of forewaters, and the one at the buttocks area, we call it bag of hindwaters. And during labor, the hand water will be trickling in gradually into the front and increasing the tension of the membranes in front of the baby. We call these two as bag of water, forewaters. So in a well-presenting baby, the baby is presenting very well. The shape of the forewaters is a cone shape, but that of the pad presentation, abnormal presentation, is not cone shape, but it's sausage shape. So take note of that and read about that. Then finally, the membranes should rupture at the end of the first stage. At full dilatation, the hand waters trickle into the forewaters. The water at the back trickle into the forewaters, increase pressure on the membrane and rupture. But occasionally the membranes may rupture early in labor or at time before labor sets in. And that's not good enough. So, and then the cervix dilates. As the upper segment contracts and retracts, the lower segment stretches and dilates or opens the cervical canal. The dilatation starts at one finger up to the full dilatation with no cervix is firm. When you go to the labor ward with the dilatation, the midwives will be describing it in the form of fingers. 1 finger, 2 fingers, 3 fingers, 4 fingers, 5 fingers, meaning each 1 finger is 2 centimeters. So when the woman reach 5 fingers with 10 centimeter dilatation, that is when the second, what do you call it, the first, second stage, and first stage and then second stage comes in. So when you hear first finger, 1 finger, 2 finger, please, what it means is how many dilatation? 2 finger, 4 centimeters. No. So that is the physiology of the first stage. When the full dilatation takes place, then the woman enters second stage. What happens during the second stage? The aim is the further descent. The baby continues coming. Now that the head, the arse is open, the baby continues coming. And what can the baby to come? We call it primary powers. Uterine contractions become stronger and frequent. And then we have secondary powers, which are the diaphragm and abdominal muscles also take part. Then we have fetal activity. The fetus also exert pressure. So these sources of pressure cause the baby to come down. I want to caution you that when the baby starts to come down, labor starts. It is just coming just like that. So we have to help the mother to deliver this baby. No obstruction on the way. So primary powers, secondary powers, and fetal axis pressure. All these things, you can see them in my lecture handouts. So there is a change. Look at second stage. The characteristics of the pain changes. It becomes very strong. And this is the time it acts like the woman wants to deliver. See, the parent down in character. And sometimes these women even call to you that they want to attend the nature's call. Antiness, make a toilet, antiness, make a toilet. What it means is that the head of the baby is pressing on the rectum, and the baby wants to come. And the woman becomes restless. When you take the woman or you look at the perineum, you see that the perineum is burdened, becoming thin, because the posterior segment push push backwards and forward, perineal body flatten out. Then the anus change into this shape. When you look at the anus of the woman, second stage, the anus change is not round again, because the anterior wall of the rectum is exposed when the head reaches the pelvic floor, making the anus look like a T. Then you realize that the vulva gaps. So when the legs are placed apart, the vertex speeds. So therefore, what I want my ladies and gentlemen listening to me is that not every woman calling for Miko toilet is ready to deliver. Not every woman. Sometimes when one calls for Miko toilet and you inspect and you see all these signs, you send her to go and deliver. When you come back, another person to call for. What I'm trying to is that anybody who calls for Miko toilet means that you have to do examination. See whether the vulva are caved. Look at the anus, whether it's this shape, that tells you that the woman is in a second. And look at the cervix, whether it's fully dilated. When on the no cervix is flat. With the birth of the baby, the second stage is complete. With the birth of the baby, the second stage, then it means the woman has third stage of labor. But before the third stage, during the third stage, immediately the baby is delivered, the uterus goes into a short rest. So short rest. We call it physiological rest. I caution that this stage should not be disturbed. If you disturb this stage, the woman will bleed. This stage is natural. You are there to assess when something is going wrong. Don't fumble with the uterus and trying to make it to deliver the placenta. That is wrong. So look at physiological rest. The woman will stop contracting. She'll stop shouting. Then gradually you see that the uterus is coming back. The uterus is coming back, you know, and then placenta will start to separate. The placenta is at the upper uterus segment. That's where it will start, and then come into a lower uterus segment. There is expulsion and descent of the placenta membranes also from the birth canal. Then at the end, the uterus itself will control bleeding. We will look at all these things. How does the placenta separate? This takes place at the spongy layer. If you remember, when the woman becomes pregnant, or we have the decidia. Decidia is divided into layers. One of the layers is the decidia shed off along the spongy layer of the decidia shed off along the perforation layer of the uterine wall, with each contraction exposing the open maternal blood vessels, so that bleeding occurs with clots that forms on the placenta. Clot that form on the placenta also pushing the placenta down, because it will lead to placenta clots, a clot behind the placenta, which also assists in the separation of the placenta. There are two methods, two known methods by which placenta separate. The exposed maternal stage sinus will produce a gross clot behind the placenta, which is known as retroplacental clot, what I just said. This type of separation is the placenta separate like an inverted umbrella and create the middle where the mother bleeds into, and then the blood clots and increase weight on the placenta and cause the placenta to separate. That method of separation we call the Shoes method. This clot helps with further peeling of the placenta from the uterine wall. All the blood loss is caught within the membranes. The placenta appears in the vulva with the fetal surface first. Fetal surface. So you see the cord with the fetal surface with the blood vessel there, you know, and the blood would bleed, the mother would bleed into the placenta. Then we have another method of separation of the placenta. We call it Matthew and Duncan method. Matthew and Duncan method. The separation of the placenta starts at the edges, like the rear umbrella. You see the way the umbrella is, that's how it separates. It starts to separate at the edges. And the problem here is that the blood continues to spill out throughout the vagina until complete separation. Immediately, the placenta starts to separate. You see a lot of blood coming. You see the blood coming, which is different from the Shoes method of separation. When the placenta descends, slipping sideways like that, the membranes are usually torn right. This method is known as Duncan method. As blood splits on the couch and the whole place becomes nasty. So two methods of placenta. Some mothers placenta separate in the form of Shoes. Some mothers Matthew Duncan method. In the Matthew Duncan method, the woman bleeds right from the beginning. These are the differences. Shoes deliver like inverted umbrella. Fetal surface appears first, followed by membranes. Blood clot behind the placenta. The membranes peel off neatly and completely. 2, the placenta descend downwards, down sideways with maternal side. Blood escapes freely and not in the sac. The membranes are ragged and parts can easily be torn or retained. So these are the differences between the two methods of placenta separation. Then after the placenta has separated, the next thing is controlling of bleeding coming from the woman. This is the most important part of the third stage of labor. And after the membranes and placenta are expelled, the uterine contractions and retractions cause the figure of 8 in myometron, figure of 8 fibers, which surround the blood vessels to arrest the blood vessels like ligatures, constricting and making the blood vessels kink, that literally tying the vessels up. So naturally, after delivery, the uterus itself controls the blood. It does not necessarily mean that after the woman has delivered, you will not see blood. You see blood, but the blood will not come plenty like the woman has in the postpartum hemorrhage. So also the uterine cavity becomes empty and the walls come together and is known as apposition of uterine wall. This also aids in the control of bleeding after the expulsion of the placenta and membranes. So that is so how do you know that the placenta is separating? How do you know? When you are in front of the woman who is delivering, number one, you see the cord that is at the vagina, the vulva, increasing in length. You see, with that elongation of the cord. When you cut the cord, you know the length. You see that the cord is increasing. It means the placenta is separating. And because the placenta is separating, you see what? Gush of blood, gush of blood. And when you touch the abdomen, small, you just touch it, you see that the uterus is harder, smaller, and mobile. The uterus rises in the abdomen, and it felt palpable above at the level of umbilicus. The placenta is seen at the vulva. When it's separated, you see the placenta at the vulva. Then look at this picture. It looks like, I want you people to admire it. That is the mechanism, that is the movement of the baby. It starts from here. And it's a various movement made by the baby. Start from here, and then the baby is coming here. That's the placenta, and vagina here. That's the anus down here. Then the head is anterior abdominal wall. Look at the baby here. Then this is a crowning of the head. And then this is the lateral flexion. And then now the baby is removed. We have the placenta and the cord. And then you have the cord increasing in length. Look at the additional length. When the baby is cut, you see that the cord has increased in length. And then finally the placenta is delivered. So this is how the baby moves. This is how the baby moves. And we call it mechanism, the movement of the baby. This is how the baby moves. All right, so the movement of baby, when the baby start coming, we have descent. It's brought about by the contraction and retraction of the uterine muscles. The baby continue coming, descend throughout the labor. The baby just, when the baby has started coming, we call it descent. You can't stop it. It will continue coming throughout the labor. Then as it comes, it keep on curving itself. We call it flexing. It's curving itself. When the head meets the resistance of the pelvic floor, it flexes, and that is good. Then internally, it rotates. When the babies come, they go to the pelvic, the posterior part of the pelvis, and rotates. This is turning forward whatever part of the fetus that reaches on the lateral area of the gutter-shaped pelvic floor first. Then when you get to the pelvic floor, it rotates. In the left occipital anterior, and the occipital, to rotate 45 degrees forward to lie under the pubic arch. And then the head rounds. This is when the occipital protuberance, escape under the head surface pubis, and the head no longer recede. When the baby is coming and you are in front, you ask the woman chim or push. The woman will push. You see the head coming forward small. Then once it relaxes, the head goes back. But as soon as the head crowns, when she relaxes, it will not go back at all again. Then extension of the head goes up. This is when the movement by which flexion to the head is made, and the sensible, the face, and the chin sweep over the perineum. And that's where the midwife will be in front, put her fingers in front of the baby or in the presenting part, and she delivers the chin, the face, everything. And then before that, she puts her fingers to see that the cord is not around the neck of the baby. If it is there, she will raise it and remove the cord. So, and then restitution, this is turning of the head, 1/8 of the circle, and undoing the twists at the back of the neck, which occurred during internal rotation of the shoulders. So the head, there will be restitution, the head will be turning, and the back. The baby is coming with the hands opened at the what do you call it? In the uterus. So when the head restitution takes place, it turns halfway. Then you have internal rotation of the shoulders plus external rotation of the head. The anterior shoulder reaches the pelvic floor first and rotate 1/8 of the circle forward, bringing the shoulder into the anterior posterior diameter of the outlet. This causes another 1/8 turning of the head. Another 1/8 turning of the head. And then you have lateral. You have the lateral flexion. Lateral flexion. Have the lateral flexion. We have the lateral flexion. This is the sideways turning of the spine, which occurs while the body is being delivered. Let's go to the mechanism. Then you understand all this. This is what we are talking about. The baby is descending. The baby is descending. The baby is descending and curving more. And the baby's head down, coming out, and it crowns here. It crowns here. See that it has crowned, and the head is raised, it's delivered. And then it rotates and become lateral. The movement, you see that the baby is turned halfway. So the midwife will move the baby in this form and then put the baby on the mother. So this is the description we just done. And I hope you read about it. Everything is in the information I gave some of you. When you read, you know what we are talking about. So how do you manage this labor? How do you manage this labor? Before the time catches up, I want to inform you some of your assignment has reached me. I don't know whether all of you have submitted. If you haven't submitted, please make sure you get your assignment to me, because I'm going to write the names of all those who submitted the assignment. So you can't tell me you submitted it. So when you know you haven't submitted your assignment, please do. It will help you. Secondly, your mid-semester to have reached here. So the last assignment announcement is that I may not I may give you another class test, short test, so watch out for the short test, and that will be purely objective, the assignment, so that it will help you people to get mark for me to grade you. I may get another before the main end of semester examination. All right. So management of normal labor. This dividing, you manage the labor as the way it is. First stage, second stage, third stage, and then fourth stage. Each one of them will have a role to play and divided according to stages. Normally, the patient has been booked. You book the patient to come to the hospital to deliver them. Then she comes to the hospital because she's ready to deliver. And then the procedure is this. Welcome here in the labor ward. Check her condition. What I want you to take note is that all the women who come to our labor ward, they come and meet different nurses. Those nurses that they meet there are not those who took care of them at antenatal. So what it means is that you need to know more about the patient when she comes to the labor ward if you are there. So therefore, what we do is to demand her antenatal card. Her antenatal record should be secure and give a full history and any important instruction that has been written by a doctor or a midwife. If the patient is not attending antenatal clinic, my friend, ladies and gentlemen, it means you have to do full examination, answer plenty of questions, because you can't just take her into the labor ward, first stage room, when you haven't asked her any question. It will be very dangerous. If something occurred, they will ask whether you have taken a proper history. So take note of that. Now, how do you manage history of the labor? You must obtain an idea whether the patient is labor, when did it start, what is the strength of the contractions, so carefully note the contractions, observe them. In the labor ward, they have a labor ward chart. All these things that I'm putting on with you here, you have a chart to record them. Frequent contractions. In the period, they give the woman what we call a pathograph. It's a graph, they take note of all this we are mentioning now. Then at the show come, is it with blood? And so on, they ask the rupture of the membrane. It should be found out whether the membranes are ruptured or intact. If ruptured, the time it did should be noted. Find out if she has eaten some food. If the food is eaten sufficient, then find out her sleeping pattern. Why do we need to know whether she has eaten? If she's coming from house and she has eaten, we are sure of the energy, especially when the labor is very early, so that she gets strength to go throughout the labor. If it started in the night and she's so sleepy, you have to know what to do. Take note of that. Then you do your general examination, appearance, general condition of the woman who has entered the labor ward. Look out for rashes and edema, if any. A temperature, pulse, respiration, as well as the blood pressure should be taken. The specimen of urine should be obtained and tested for albumin, sugar, acetone, and protein. All these have to be tested in the general ward. If the membranes are fractured, then either the midstream or catheter specimen of the urine should be obtained for the true nature of the urine, as the liquor contains albumin. If albumin is present in the urine, it is a sign of pregnancy-induced hypertension. So you act, or the labor ward staff will act. Then you are supposed to know this. Even when it has been done, you have to examine the abdomen, know the lie of the baby, know the presenting part of the baby, know the position of the baby, see whether the head has engaged, and then take vital heart. in the labor ward, all this thing has to be done. So general preparation to has to be done. You shave the women are told to shave on the vulva, the hair on the vulva. And the simple thing is that even if you haven't shaved, the baby will come anyway. But when you shave, that place is shaved nicely, Sakura type of shaving, or you cut very down. What it means is that, you see, when the person delivers, there will be blood, there will be mucus, everything. It will be difficult for you even to clean the woman after she had delivered. But when she shaved, it is very nice. So at the same time, the vulva is inspected for show drainage of liquor, etc. And then formally enema is given, but now they tell them to give themselves enema in the house. But they see the need for enema is evacuate the content of the rectum. That is because the content of the rectum can cause labor obstruction. So you need to remove whatever is in the rectum. But if the woman has had problem with bleeding in her previous deliveries, then there's no need to do that for the woman. Then the woman will bath, you advise her to bath, in a good maternity where they have showers. When the labor is very early, she bath. And when she bath, the physical care, if everything is normal, she should allow to get up and walk about during the first stage. She can adapt any position she wants. There is no prescribed position for a woman who is in labor in the first stage. Her comfort should be also taken care of. Personal toileting should be taken care of. You help her, you clean her, or you give her nice maternity dress to wear in the labor ward. Make sure you advise of she should practice aseptic techniques. Some of them, when they are moving around or they are in bed, when they are packed under them, fall down, they bring it back and cover it. You make sure you advise her on that. You care for the bladder. If there is urine, the urine is removed. Otherwise, it can cause obstruction. Fluid and foods should be taken care of so that, but if it should be light soup or something. If it is getting closer to the delivery, you have to be very careful with food because we don't know the outcome of the labor, whether the woman will go to theater or not. She should rest. If she comes very early and she's finished sleeping, she should rest. And then she also be given good sedative analgesics and relaxant can be given, but you have to be very careful the type of sedative that you are going to give, because then you check the progress of labor. That is where the photograph is used. Characteristics, BP that you take, the descent of presenting patterns should be noticed. The head, which is high, up above the brain, indicate disproportion. So careful records taking is very important, and observation and careful records, as we said, statistical purposes, we take records of hair, maternal pulse, blood pressure, uterine contractions, fetal heart sound, drugs that she has taken and she's taking, the intake and output chart, urine testing, membranes, we check all these things. So that is the first stage management. That brings us to an end of this lecture this afternoon.
Thank you,
As I said, some of your assignments have reached me. If you haven't gotten it to me, please do, because you can't say that you have brought it, because I'm going to list the names of all the lessons I've received. And I'm also planning to give you an objective test, which is an assignment class test before we write the main semester. So thank you very much for listening. Any question?
I have a question, sir.
I can't hear you well.
I want to know the
Pardon? Hello? Hello?
estimated loss of blood during labor. Hello, sir.
Yes?
Sir,
I'm
estimated loss of blood during
what's the measure of blood?
estimated loss of blood during labor.
The measure loss of blood. At the end of the labor, you have to do that. We haven't reached there. You have to measure the blood loss. And that gives the idea whether the woman has postpartum hemorrhage or not. When you deliver the placenta, you measure the blood. Remember, one of the separation of placenta is Schu's method, which is inverted umbrella method, and the blood clots on the placenta. All this blood, when you deliver placenta, you collect them in a measuring cylinder, and then we measure the blood loss. That's very, very important because we need to know the amount of blood the woman has lost during the delivery. That's very important. So we'll get there. We have to read there. Hopefully next week we'll go there and pass there. God willing. All right.
Hello, sir.
He left.
Oh, okay. Thank you. Hello, you can ask your question.
But you can say what you want to say.
It's no more on the page, and she wanted to ask him. So we call it a day.
Hey, Yapon.
Sebium Yapona.
Yapon.
Quite medium. But the speed is too much. I was expecting that someone would draw his attention to.
Hello?
Yes.
Hello.
The rep, at least they should try and talk to him. The way teaching gets speeding, the questions that we
Abba,
I don't even know.
just speeding.
Yes.
Abba.
Please,
Please,
looking at what
there.
please looking at what Sister Krista said yesterday, the way this man is taking us through, it seems we don't understand certain things, but we are finding it difficult to draw attention that
Like he doesn't want to
Please,
listen
still.
to.
Please, sir is still there. Please.
Can we do it on a
Aye.
general?
Sir is still there. So if you want to address your issue,
dinner
please.
so there are certain topics. So in this case, what are you going to do? Because rates that is going we can do something about it. Hey, pressure no so.
If
And
I
what
may
do you
be,
think? We should say it like
sir is
that.
still on the platform. Hello.
Yes, dear.
Yes, sir is still on the
Yes.
platform. So if you want to address it, maybe he can unmute because he has just muted.
Reps,